Welcome to AETCM, the emergency medicine channel. Today let us discuss about heart blocks. One of the most common cause for bradycardia is heart block. We all know that heart block means it's an AV block, atrioventricular blocks. The rhythm starts from the SA node, then it goes to the AV node. From there it go to the bundle of his Purkinje fibers, all these things. So the problem is here, somewhere here. Okay, SA node to AV node conduction is blocked. That is the main problem. So it is the delay or interruption in the transmission of impulses from the atria to ventricles due to an anatomical or functional impairment. That means sometimes the problem will be in the structure, the anatomical area. Sometimes the problem is a electrolyte imbalance or some poisoning or something. So if normally when P waves are there, QRS complex are, it's a regular rhythm. Okay, so it's a regular rhythm. And if there is a conduction defect, what happens is sometimes only one may delayed, that is first degree heart block. Second thing is P waves may come but there is no QRS. Ultimately it will lead to bradycardia, the heart rate will become low. So that is a problem of heart blocks. Different type of heart blocks can sometimes produce severe bradycardia. There are three important types of bradycardia: first degree, second degree and third degree. Other than that, we have bundle branch blocks. We are not discussing bundle branch blocks. We are discussing AV blocks, atrioventricular blocks. So this is a conduction system of heart. We have already seen that from the SA node. So here you can see the SA node. From the SA node, the conduction go to the AV node. From the AV node, it will go to the ventricle. So block is somewhere here. So you can see here, block is somewhere here. So that produces AV block or heart blocks. So the you can see here, SA node generate impulses. That time we get a P wave. Then you get QRS complex where the ventricular activation occurs. So P wave is originated from the atria. This is the conduction time from the SA node to AV node. Then you get a QRS complex, that is a ventricular activation. So every P wave will follow by a ventricular activation. So if there is a block, sometimes what happens, P wave to QRS complex time is delayed. Sometimes that is first degree heart block. Sometimes after P wave there is no conduction at all. You can see the second P wave, then QRS complex. So here QRS has to come, that has not come. There is also type of heart block. Now you can see here PR interval. After P wave there is onset of SA node to the QRS complex, that is a AV node activation. That is the PR interval. Okay, so PR interval means onset of P2, onset of QRS complex. That is PR interval. So PR interval, onset of P2, onset of QRS normally is 120 to 200 milliseconds. 120 to 200 milliseconds or 3 to 5 small squares. So that is very important. 3 to 5 small square. This is a one small square, second small square, third small square, fourth small square, fifth is there. So this is in between. You can see here it is between 5 small squares. Okay, so 3 to 5 small squares. 3 is this one, 3 small square, 5 squares are this one. Okay, so the minimum is 3 squares, maximum is 5 squares. So PR interval. Now first degree heart block means PR interval is prolonged. So you can see here SA node to AV node conduction is normally occurring here. AV node conduction is normally occurring here. This is SA node to AV node conduction. So P wave comes here, QRS comes here. Okay, so that's a normal conduction. But due to some reason, if there is a prolongation of the P wave to RR QRS complex, there is a delayed conduction occurring here. So what happens is, so there is a normal conduction is very fast. In between something happens and it get delayed. Then what happens is P wave is formed normally. PR interval is prolonged. That is due to a problem in the conduction, but it is not a complete problem, it's a partial problem or a small problem. PR interval is prolonged. So here you can see the P to R wave is only 4 squares. Here what you are seeing is P to R wave is around 9 small squares. So PR interval is prolonged or long PR interval. This is called as first degree heart block. So it's a partial block, it's a first degree heart block. So here you can see, here the P wave starts and QRS starts here, around 9 squares are there, that is PR interval is prolonged. Normal PR interval is 3 to 5 small squares. First degree heart block. Now there are a lot of causes for first degree heart block. So these causes can sometimes cause second degree or third degree also. Now increased vagal tone sometimes produces first degree heart block. Athletic training, during athletic training some can have bradycardia first degree heart block. Inferior wall myocardial infarction can produce first degree heart block. Mitral valve surgeries, myocarditis, electrolyte disturbances like hyperkalemia, AV nodal blocking drugs like beta blocker, calcium channel blockers, digoxin, this is one of the important cause for first degree heart block. So the problem is somebody is on beta blocker, you can see PR interval is slightly prolonged and bradycardia. In that situation, you should not increase the dose of beta blocker. You can just add some other drug to control the heart rate. But calcium channel blocker and beta blocker, if the PR interval is already prolonged, better to avoid this type of drugs. Or any patient is already PR interval is prolonged, no need to add a beta blocker to that and increase the problem. Okay, so if you already know that PR interval is prolonged, better to avoid beta blockers and calcium channel blockers. And sometimes it can be a normal variant, that is very important. Patient is absolutely normal, but ECG shows PR interval prolonged. So PR interval prolonged, you can see here PR interval is starting from here to here. So around 4 squares here, 4 squares here, 5 squares here. So 8 plus 5, 12 squares are there. Okay, so it is very wide. PR interval is very much prolonged. Now AV block second degree is another problem. So here what in first degree block we have seen is PR, this is a normal PR interval. Okay, normally conduction occurred very fast. So first degree means the conduction is like this. So there is some delay due to some problem. So PR interval is slightly prolonged. So PR interval is prolonged. But it's a partial block. So there is no complete block here. Actually electrical activity is going, but it is a partial block and it is only delayed. But what happens in second degree heart block onwards? So you get a normal P wave, then PR interval, then QRS complex, again P wave, then QRS complex, then a P wave. Suddenly there is no conduction and third P wave comes and QRS complex. So what happens here is, here we expect a QRS complex, but that is missing. So that means suddenly during conduction, suddenly there is a block here, and that complex alone is, or that electrical current alone is not transmitted to the ventricle, and you are not getting the ventricular activity, that is QRS complex, you are missing. So P wave is there, but there is no QRS complex. That is second degree heart block. So that is very important. Sudden dropping of QRS complex after P wave. So P wave is there, SA node is activated, SA node is activated here, but it is not conducted to AV node. Okay, so P wave is there, but QRS is missing. That is second degree heart block. And in second degree there are two different types that we'll see. First type is prolonged progressive prolongation of PR interval. So P wave is first PR interval is okay. Second PR interval is prolonged. Third PR interval is Third PR interval is again prolonged. And fourth one, P wave is there, but you are not getting any QRS complex. So here somewhere you need to get QRS, but it is not there. Then next P wave comes QRS complex. So progressive prolongation of the PR interval, sudden drop of one QRS complex. That is Wange-Bach's phenomenon, or this is type 1, Mobitz type 1. It's very important. Mobitz type 1 second degree heart block. or otherwise it is called as Wenger-Bach's phenomenon. So either Wenger-Bach's or Mobitz type 1 second degree heart block. Okay. So another, so this is a classical Wenger-Bach's phenomenon. So PR, you can see here PR interval is started prolonging. Suddenly we missed one QRS complex. So PR interval is like this is smaller, this is smaller, this is little larger, this is more larger, and QRS complex is dropped. Okay, this is Wenger-Bach's phenomenon. Now you can see here. So here QRS is missing. QRS is missing. So sudden drop of one QRS complex is second degree heart block, and then if the PR interval is slightly prolonging, the second PR interval is prolonging, and third one is missing. That is Wenger-Bach's phenomenon. Like previously we have seen 2-3 complexes. After 2-3 complexes we are missing one, but here after every 2 complexes you are missing one. So that is a high degree heart block. Now Mobitz type 2 block is slightly different from Wenger-Bach. Wenger-Bach, you have already seen that progressive prolongation of the PR interval and drop of one QRS complex. But here there is no progressive prolongation, all PR intervals are equal and suddenly you are missing one QRS complex. So this is Mobitz type 2, a second degree heart block. So that is very important. These two are different, Mobitz type 2 and Mobitz type 1. So Mobitz type 1 or Wenger-Bach is progressive prolongation of PR interval and sudden drop of one QRS complex. Whereas Mobitz type 2, there is no progressive prolongation, sudden drop of one QRS complex. Okay. Now that is a lower degree Mobitz type 2. Lower degree means it is not very severe. Once in a while you are getting missing one QRS complex. But high degree second degree heart block means second degree heart block, high grade. High grade means, so here you can see there is PR interval, here QRS is missing. This is their normal complex, here QRS is missing. So this is 2:1 or high grade second degree heart block. Okay. So it's a high grade second degree heart block. It just mimics a complete heart block. So it is almost complete heart block, but the criteria is not complete heart block according to ECG criteria. Now, Mobitz type 2 second degree heart block. So you can see the PR interval is normal here, normal here, normal here, but you are missing one QRS complex here, you are missing one QRS complex here. So you understood that there is a P wave, SA node is activated, but there is no QRS complex. Next P wave comes, then QRS complex comes. That is second degree Mobitz type 2 heart block. But there is another entity called as sinus pause. Sinus pause means, so here what is happening is SA node is activated, but it is not gone to the AV node. That is a problem here. SA node activated by getting a P wave, but you are not getting a QRS complex. Whereas in sinus pause, there is no P, no QRS. So there is no activity from here SA node, and since there is no activity, it is not conducted. So what you are seeing here is, so P to QRS is PQRS is there, PQRS is there, PQRS is there. Suddenly you are not getting a P wave, you are supposed to get a P wave somewhere here, then you need to get a QRS complex, next complex comes here. So this P is not there, this QRS is also not there. That is slightly different from Mobitz type 2. Okay, this is called as sinus pause. Sinus pause means sinus node is not working, so that you are not getting a P wave, and because of that electrical activity is not there, you are not getting a QRS complex also. Now here you can see here, so here one QRS is missing. all are equal or slightly, this is slightly increased, then QRS complex. So this is a Wenger-Bach's phenomenon. Now third degree heart block means SA node to AV node conduction, you should remember P wave comes regularly, but due to some reason it is not going to the ventricle. But since ventricle is not getting any connection at all, ventricle also start beating in its own rhythm. Okay, it may be slightly lower than the atrial rhythm. That's all. Okay, so P wave comes regularly because SA node is activated regularly, but it is not conducted to the ventricle due to some complete block, and since ventricle is not getting electrical current, it acts by its own and it produces QRS complex. But atria beats in its own rhythm, ventricle beats in its own rhythm. You can see here, this is P wave. Next P wave comes regularly. You can see here, P waves come regularly. Okay. So there is no association between QRS complex and P waves. But both are coming regularly. The QRS complex comes regularly, P wave comes regularly, but there is no association, like every P wave is not followed by a QRS complex, or every one or two P waves are not followed by QRS complex, and even if it is followed, it is totally irregular. So that is complete heart block. So you can see P wave marches regularly. In the regular interval they are coming. P waves are coming regular interval. QRS is coming regular interval. QRS is slightly lower in ventricular rate. So normal atrial rate is around 70. You can remember 70 is atrial rate, but your ventricular rate is somewhere around 40 to 60. So that slow response is seen here, and it is fixed. Okay, QRS complex are coming regularly, P waves are coming regularly, but there is no association between P and QRS complex. This is complete heart block. So there is no association between SA node to AV node. SA node is completely cut off from the AV node, and this electrical activity is not sent to the ventricle. So P waves are coming regularly, QRS complex are coming regularly. There is no association between P and QRS complex. That is very important. So this is complete heart block. P waves are coming regularly. You can see here P wave, P wave, P wave, P wave, P wave. So all P waves come regularly. So here one important thing is you are not seeing P wave, but the baseline is wavy, like atrial fibrillation, you know, fibrillary wave, then QRS complex, then P wave, then QRS complex, P wave, then QRS complex. In atrial fibrillation, we give beta blocker, diltiazem, digoxin, all these things we give. What happens is sometimes they control the heart rate, but still the QRS complex will be irregular. You can see here it is irregular. QRS complex is always irregular, but rate is controlled. Rate is very slow. But what happens here, there is atrial fibrillation. You can see here AF is there, but QRS complex are coming regularly. RR interval is equal. So that is a sign of complete heart block. So complete heart block with AF, that is an important topic, because many of these patients come to emergency room with severe bradycardia. So when you are examining, patient will be already having atrial fibrillation. They may be on beta blocker, diltiazem, digoxin, all these things. All these things control the rate. But even when the controlling rate is there, they will never be regular. They will be completely irregular if the patient is having AF with controlled ventricular rate. Controlled ventricular rate is a very important thing, because we have to control the rate in atrial fibrillation. But if the patient has developed complete heart block, like digoxin toxicity, they can go to complete heart block. So it will be totally regular. This will be totally irregularly irregular. This will be completely regular. Now, management, we should know what is the reason for all these heart blocks. So it can be ischemia or vagal tone increase, or drugs which can produce a complete heart block, or this one. So we have to avoid these triggers. Then we can give atropine. Atropine is one drug which can increase the heart rate in most of the patients, but it may not work in second degree or complete heart block. It only acts when there is a bradycardia, but we can try atropine if there is a severe bradycardia. Mostly it will not work. Then you have to correct the electrolyte imbalance, all these things. Pacing is the most important treatment for complete heart block. So you can see here, any patient who is having severe bradycardia, it can be complete heart block or any type of bradycardia, you can try atropine. Okay, but the problem is complete heart block or second degree heart block, atropine will never work. Then if atropine is not working, you are working in a peripheral settings, you can go for alternative drugs, isoprenaline, adrenaline and all. But most of these things may not improve the patient's condition, so you have to go for temporary pacing, and then once the patient is shifted to a major center, you can go for permanent pacing. Dopamine can be tried. Glucagon is given in patients who is having beta blocker induced toxicity. So glucagon is a drug of choice. Then some patients may go to acetol. Okay, so that also has to be treated. But the most important treatment for complete heart block, high grade second degree heart block, is pacemaker implantation. You can put a temporary pacemaker initially from the ER, but most of these patients may require permanent pacemaker. So this is a pacemaker that produces current like your SA node. From there it will go to the ventricle. So we have discussed about different types of heart block. So first degree heart block, second degree heart block. In the second degree heart block, 2 types of heart block. Then third degree heart block. The problem is most of these patients, when they have a significant heart block, they can have like dizziness, giddiness, altered behavior, loss of sensorium, seizures. All these things can be there. If the patient is having a bradycardia, but if they are asymptomatic, they may not require treatment. But if the patient is having bradycardia due to any reason, whether it is complete heart block, second degree heart block, or due to some other drug toxicity, whatever it is, they may require treatment. The immediate treatment for any type of bradycardia is atropine. But second degree heart block or third degree heart block may not respond to your atropine. Most of them, if they are symptomatic, they may require pacing. Thank you.